I'm unmuted. On behalf of the Independent Medical Practitioners Association of Sri Lanka, let me welcome each and every one of you for this very informative webinar on COVID-19 vaccines and what the medical profession should know. I would like to thank our guest lecturer, Professor Suranjit Seniratne, who's speaking on this webinar all the way from United Kingdom. And also we have a lot of participants from United States, UK, and it's the timing at the moment in Sri Lanka is evening 6:37. But we are having a lot of participants from Sri Lanka, India, and Southeast Asia also. And the timing in UK is a lot of participants attending this webinar from United Kingdom, and we have several participants. And thank you everybody for joining us and giving us this opportunity to enlighten the medical profession on the COVID-19 vaccines and what the medical profession should know. Now I will hand over to Dr. Mubarak, the consultant cardiologist, who is going to be the moderator for this evening's program. Thank you.
Thank you, Dr. Hazari. Hello, welcome everyone. Thank you for joining us from around the globe for today's webinar. My name is Dr. Mubarak and I'll be moderating this session. Today's topic is COVID-19 vaccines and what you need to know by an international expert on immunology by Professor Suranjit Seniratne from the United Kingdom. Hello, Professor, welcome to this webinar.
Hello, Mubarak.
Professor Seniratne is a professor and consultant in clinical immunology and transplantation at Royal Free Hospital and University College of London, UK. He has completed a Doctor of Philosophy at the University of Oxford, UK. He obtained his MD from Colombo, University of Colombo, Sri Lanka, a long time ago with me at that time. He has authored more than 252 research publications in peer-reviewed journals. Yes, Professor Suranjit is a president of the UK Sri Lanka Immunology Foundation. Today, Professor Suranjit will speak to us for about 20 minutes, and it will be followed by an interesting question-answer sessions. I hope Prof is ready to answer all your queries regarding vaccines. If you have any questions during the presentation, please type them down into the question box in your control panel. Please type them down while the lecture is going on. I'll try my best to bring them up during the question and answer sessions. Without further delay, I call upon Professor Suranjit to take over. It's to Professor Suranjit, please.
Thank you very much, Dr. Mubarak and Dr. Hazari, for the invitation to give this talk. I'll just share my screen. Just a minute. Thank you very much to the IMPA for inviting me to give this talk. Right. Can you see the screen now? Yeah. So what I'll immediately go into the talk directly. And what I'm going to do now is initially give you a basic idea about COVID-19 vaccines, what you need to know. If you look at the world, it is a major problem. It has been a major problem over the last 14 months. There are 108 million cases with 2.4 million deaths. So it's a big problem. In Sri Lanka, we are blessed with there have been 74,000 cases and unfortunately 384 deaths. The numbers are very much lower than other countries like the UK, US, and India. In the US, it's 27.5 million. And what people say is you take the number of cases, multiply by 4 to actually work out the actual number of possible cases that are around. So that those are big numbers, 481,000 deaths, and that's a big number. And you know how COVID has changed so many things in our lives over the last 14 months. Vaccination is one of the important facets in management and control, but we must remember that wearing masks, social distancing, hand washing, etc., cannot be forgotten. And just because we vaccinate, it does not mean that other things should be just forgotten and put aside. You can see from this graph that nearly over 100 million doses of vaccine have been administered in the world. That's a very important thing, because the father of vaccination said until they give 3 million doses of vaccine, he's nervous because could there be any untoward effects. But now we must remember that over 100 million doses, over 40 million doses have been given in the US, China, around 40 million, in the United Kingdom, 15 million, India and Brazil, they have been leading. And this is vaccination started in December, and you can see the pace at which it is going. So this is an important facet to remember. Over 100 million people have been vaccinated, predominantly with the 3 approved vaccines in the West and the other 2 vaccines. That's the Gamaleya in Russia and the Chinese vaccine, which we'll come into. So what I'll do here is talk about give you some basic concepts of immunology to understand the vaccine responses, some immune changes, and tell you that there are both antibody and cellular changes, talk to you about the COVID vaccines, and the important topic that everyone is talking about now is the new variants of SARS-CoV-2 and what is the effect on vaccination. So if you look at the immune system, you have viruses, bacteria, and fungi always trying to attack our body. You have danger signals. You have 2 different parts of the immune system, innate and adaptive. And then you have the adaptive, the second part has antibodies and white cells. For easiness, we'll just describe it like that. Antibodies can be different types, IgG, IgM, etc. And if those components should come into play when you get infected with a virus, bacteria, or fungi. If they don't function properly, you get immune deficiency, and that is something that immunologists, an aspect that immunologists manage in their clinic. If it doesn't function properly and it produces antibodies and white cells against our own body, you get autoimmunity. And if it produces these same components against things found in the environment, you get different allergies. So you find that different components of the immune system, including antibodies and white cells, should work in concert to be able to get rid of the different harmful agents that are going to attack us. Now you have, as I told you, there are different types of cells. There are neutrophils, there are red cells, there are eosinophils, there are basophils, T cells, B cells, etc. But the immune system, the important cells, we have to remember, are the T cells and the B cells. And the important aspect to remember is when you get a natural infection, these cells will get activated and there'll be something called immune memory. So that if you get infected again, the immune system gets into action very, very fast. So what we're trying to do with vaccination is trying to produce that immune memory so that once the person is vaccinated, if they meet the virus SARS-CoV-2 in this instance, they would have immune memory and could respond appropriately. So this is a schematic showing that the different types of cells act together, the T cells, B cells. B cells will become plasma cells and produce antibodies or immunoglobulins, and the T cells will produce cytokines. And cytokines are chemicals that immune cells use to talk to each other. And you will know in SARS-CoV-2 cytokines were produced. If you had too many cytokines, then you had a hyperinflammatory state. So you do need some inflammation when one of these organisms comes into your lung. But if there's a hyperinflammatory state, then that is a problem. So let's go to the virus. And if you look at the virus, you can see that on the surface, there are these different proteins called spike protein, which all of you all would have heard at some stage. And there are, but you must remember it's a RNA virus with some protein attached, the nucleoprotein. And then you have other proteins, including envelope and membrane. So the important take-home message here is you have the spike protein, which is important in attaching to a receptor on the cell, because a virus needs the machinery of the cell to function. The virus must come, bind to the surface of the cell, enter the cell, take over the cell, and get the cell to do its bidding. That is, the virus comes in and starts multiplying and producing a lot of viruses which are within the cell. So this is schematic to show that there are different components of spike protein, and just to get you to concentrate on something called receptor binding domain, because that's a very important area of the spike protein, which we want to ensure that that doesn't change too much, because the virus changes a lot in that region that can affect immune recognition. That is how the immune system will recognize the virus and gets rid of it. So that is a quick run through some basic aspects. T cells, B cells, you need a good immune response. You have the virus, and on the surface, you have the spike protein. And the spike protein binds to the receptor and enters the virus enters the cell and takes over the cell. Next, we come on to tell you that there are a whole range of immune responses during a SARS-CoV-2 natural infection. That's you meet the SARS-CoV-2, and then you'll find that you have the CD4 cells, CD8 cells, B cells, you have cytokines, you have eosinophils, basophils, neutrophils, a whole slew of immune cells coming into action. But the issue is that if you allow all people to get SARS-CoV-2 with the assumption that you will get immunity, then the issue is that a certain percentage will get very severe disease and end up in hospital. They will end up in ITUs, they'll overwhelm the hospitals, many will die, and that is not a way in which countries could go in, because it will overwhelm the system. And that was thought of initially early in the pandemic, but that was why it was found that it was not an appropriate method to go down, and therefore other methods like social distancing, wearing masks, etc., came in, lockdowns, etc., came, especially in the UK. We have had 3 lockdowns now. Those came into play because of the fact that you could not allow a whole number of people to get infected with SARS-CoV-2 and get COVID and then try to get immunity in that way. So these are the sort of cells that come in, the CD4 and CD8 cells. After some time, you get antibodies, IgM antibody and the IgG antibody. Now, the problem with natural infection alone and getting immunity, that yes, we get immunity after natural infection, but they noticed that the antibody levels were starting to wane after some time. Here it was about 4 months, 5 months, antibodies started waning. That is, at the beginning, days after infection, there was a certain amount of antibodies, and that started waning. Now, that was something to watch, because if we use a vaccine, would we have to give the vaccine every year, every 2 years, etc.? That came into the picture. Or could the person get infected and then be reinfected because their immune system has dropped up? Now, I told you that it's not only antibodies. Antibody is one component of the immune system. You have cellular component, that is the cells, the white cells, that lymphocytes, and you have CD4 cells, CD8 cell, and many different types of cells. Specific immune cells can be produced again, the spike protein and the other protein. So this schematic shows you that there is a polyclonal response. Polyclonal means a multiple, not a single response, but a widespread response that occurs after infection. And that is what we are trying to do with regards to vaccination, to get a polyclonal response, a sort of diverse response. So next we come on to the COVID-19 vaccines. As I told you, more than 100 million doses have been given. This is an article which we wrote about the landscape, and there's another article that is coming up, updated article, but this is the original article that we wrote about the COVID-19 vaccines. This was also came in a paper, and you could read it when you all have time. And the important thing to remember, there are phases in which a vaccine is produced. That is a preclinical stage, phase 1, phase 2, 3, and 4. And these stages were followed in producing this vaccination. It's very important to remember, shortcuts were not taken. The difference process that occurred here was that the phases occurred parallelly. That is, when phase 1 and 2 were going on, phase 3 had already started. That is the reason why we were able to get a vaccine so soon, rather than waiting 10, 15 years to get a vaccine, because all the phases, while animal studies were going on, you had the phase 1, phase 2 were starting at the time. While the studies were going on, manufacturers were making the vaccines. And we know that certain vaccines have failed, and countries had to throw those different vaccines. In Australia, that happened. A company called CSL, their program failed. So not all vaccine programs have been a success. So the different types of vaccines that you have, all of you all know that there is the live attenuated. You take the virus, you disable it to such extent that it can't cause infection, and you can give a live attenuated, or you can get a killed vaccine, inactivated vaccines. And those vaccines are well known to people because they have been around for a long period of time. But it takes time to produce those, and it has to be, you have to have special precaution because we're not dealing with live viruses, etc. Even if you have to kill the virus, you have to get the live virus initially. Then you come, so that's two methods. The next method was a protein-based vaccine. We are waiting for that vaccine to come. That's a Novavax vaccine, where you take subunits, parts of the virus, and inject it to the person. That is a protein subunit vaccine. The newer vaccines which have already been approved are the mRNA vaccine, which is the Mrna and the Pfizer vaccine. Here you take the mRNA, messenger RNA of the virus, of the SARS-CoV-2 virus, spike protein, and you inject it. Once it goes into the cell recognizes that, produces the viral protein, and the immune system responds to it. So that is the mRNA vaccines, and that is that mechanism by which you find that the proteins are produced in the cell, and then you find the immune response coming. With viral vector vaccines, the Oxford vaccine, the AstraZeneca vaccine, what you do is you use in the AstraZeneca vaccine, you use a chimpanzee cold virus, adenovirus, cold virus, which you use to get that part, the genetic part of the SARS-CoV-2 spike protein into the cell. And when it goes into the cell, again, it is changed to mRNA, protein, and then the immune response occurs. So what you are doing is you're using the adenovirus, the chimpanzee adenovirus, to get the component into the cell. The Jnj vaccine is coming out, that is the Johnson & Johnson. It is using a different adenovirus. It's a human adenovirus, adenovirus 26. And you find that the Gamaleya, the Russian vaccine, is using two adenoviruses, that is adenovirus 26 and adenovirus 5. So these are what we call viral vector vaccines. So in summary, there are 5 types: the inactivated, live attenuated, the inactivated, the protein-based, that's protein subunit, the viral vector vaccines, and the genetic mRNA vaccines. And what has been approved at the moment in the West are the mRNA vaccines, that's the Moderna and the Pfizer vaccine, and importantly, the Oxford AstraZeneca vaccine. So this is a schematic, again, to show the mRNA vaccines. It's injected, goes into the cell, it produces the viral spike protein, and then you have the immune components, immune response against the spike protein. Next, you have the viral vector vaccine, which does not, it has been disabled so that it does not multiply within the cell. That's the adenovirus, the chimpanzee adenovirus doesn't multiply within the cell. It just acts as a shuttle to take the component into the cell. Proteins are produced, the spike protein produced, and the immune response is produced. So this is a schematic. Now we have heard so much Pfizer vaccine, Moderna vaccine, AstraZeneca vaccine, Gamaleya vaccine, etc. It's a schematic to show you some of the properties. All these vaccines listed here needs 2 doses. I'll tell you about another vaccine that only needs 1 dose. 2 are RNA vaccines and 2 are viral vector vaccines. See the storage temperature. RNA is very unstable, so it breaks down easily. So the Pfizer vaccine is -70, Moderna -20, and this is difficult in certain parts of the world, in Africa and certain parts of Asia. Even in certain parts of the UK and US, it's difficult when it comes to these temperature. AstraZeneca and Gamaleya, see the temperature, normal fridge temperature. Effectiveness, 95%, it was wonderful to get 95%, such high effectiveness with Pfizer Moderna vaccine and the Moderna vaccine. AstraZeneca was 60 to 90%, and the Gamaleya vaccine was 92%. See the cost of the vaccine, the cheapest is the AstraZeneca vaccine. They're doing it at cost, and that is why most countries in the world are targeting the AstraZeneca vaccine to be given to their population because of easiness of transport and the sort of that it is affordable to the population. So next we come on to 2 other vaccines that should be coming up. The Jnj vaccine should be maybe approved at the end of this month in the US by the US FDA. This was that they did a big study, but the important thing to remember, they had good response, 72% in the US, because 50% was given as the cutoff by the WHO or FDA to approve a vaccine. But there was a slight decrease when it came to South Africa. That was an important thing to remember. 72% in the UK, but 50%. But the important thing to remember is that they were preventing severe disease and deaths. We want to prevent those 2 components because that is the one that is affecting the outcome of this pandemic. People getting into hospital, into ITU and dying. If they get mild disease, it's not as bad as the person getting into hospital and overwhelming the health system. The Jnj vaccine is generally safe and well tolerated. Again, at 2 to 8 degrees, 1 billion doses and FDA approved, well is expected. The important thing from Sri Lanka is it will take a bit more time for the Jnj vaccine to come to Sri Lanka because the Americans would be taken that vaccine first, because they don't, at the moment, the US does not have a viral vector vaccine, and that is the first viral vector vaccine that will come into the US, while in Europe and in the UK, you have a viral vector vaccine, that is the AstraZeneca vaccine. Novavax vaccine, again, very highly built. They did a study, it's a protein-based. I told you the 3rd type, the subunit vaccine, but in the UK, it was close to 90% effectiveness. But in South Africa, there was a drop in effectiveness because these studies were done when the new variants were circulating. And it was when people were non-HIV, it was about 60%. And again, this is a vaccine that is targeted a lot into the low-middle income countries. Valneva vaccine, it's another one. I won't go into detail here, but there is a big push again. This is an inactivated vaccine, where the whole virus is used, inactivated vaccine, and there's been a partnership with the UK government to produce a large amount of vials of this vaccine, and this would be something that will be coming, say, in May or June. So now what about dosing schedules? I'll quickly go through certain properties of the vaccine just to give you, and we can discuss in the question. Now, Pfizer was 3 weeks, Moderna and AstraZeneca 4 weeks. That was the original presumption which were done in the clinical trials and the data that was coming up. But on the 30th of December, UK Chief Medical Officer said that the second dose can go up to 12 weeks. And they want to prioritize the first dose so that more people could get the first dose and have some protection rather than giving a smaller number of people both doses and not giving some any dose. Now, the effectiveness after single dose, which we'll describe in the Pfizer, was about 52%, but it increased towards the latter end of the 21 days. That's a very important thing to remember because the immune system takes some time to act. And AstraZeneca, it was about 73%. And now, at the moment in the UK, it is not given at 4 weeks, the AstraZeneca, but it is delayed. And there is a recent preprint a paper that has come, which shows that presumably increases the immune response if you delay it more than 4 weeks and give it before 12 weeks. After receiving the vaccine, will you test positive for COVID-19? You won't test positive in the PCR test. That's very important because some people want to travel and they want to ensure that they're negative, but they can. The expectation you test positive to the spike protein IgG. So therefore, when you're doing a antibody test, it must be an antibody test that looks at the antibodies to not the spike only, but to other components of the virus. That's a very important thing. But that's more to the lab because the lab should get the correct test more than the general population worried about this. That's an important thing for the lab and the clinicians to take into account. Allergic manifestations came into prominence in December with the RNA vaccines, where Pfizer, people receiving the Pfizer vaccine developed, few people developed severe allergic reaction. This was the study that was published by CDC. There were 21 cases. There are more cases now. And the initial advice on the MHRA was anyone with a history of anaphylaxis to food vaccine or medicine should not be given the Pfizer vaccine, but that has been downgraded now, and therefore still people with anaphylaxis are getting the vaccine under observation for 15 to 30 minutes, unless they have anaphylaxis to one of the components of the vaccine, that specific vaccine, that's the RNA vaccine. With the AstraZeneca vaccine, allergic responses have not come into big focus. I know that there have been some adverse effects which we'll talk in the discussion, but allergic responses have not come as a major issue with the AstraZeneca vaccine. COVID-19 and pregnancy and breastfeeding, I've spoken about this, I've written about this, so I won't go into detail, and that can be checked in the sort of presentation that I've done in another forum. So basically, what you can see is, I told you this, we have given more than 100 million doses. Israel has leading it per 100,000 population, and then you can see the other countries that are coming up and catching up quite soon to vaccinate their populations as rapidly as possible. So if you look at this, the COVID-19 vaccines, you have the Oxford vaccine. It is the trials that were done. It is suitable for adults at the moment. Children have not been included, although Oxford is starting a vaccine trial up to children going up to 6 years of age. And you have that the vaccines are given up to 12 weeks apart. And then in the Pfizer vaccine, it's safe and effective, strong immune response, 95%, and the two vaccines are given 3 to 12 weeks apart. There is some controversy about that. There are adverse effects. All medication vaccines produce adverse effects, and these are the adverse effects, but we try to mitigate those adverse effects and ensure that those are not severe adverse effects. Mild adverse effects like arm pain, headache, muscle aches, chills, and fatigue can be controlled appropriately. So vaccine enthusiasm has increased after the vaccines have been rolled out. You can find that a number of countries that were previously not very willing to get vaccines the vaccine hesitancy has reduced across the world, and that is helpful in rolling out the vaccines. And this is a schematic showing the position in Brazil, United Kingdom, China, etc. Still, there are some countries where there is some vaccine hesitancy, like France, Russia, etc., which should be considered. And it appears to be that the vaccines are working, because Israel, which has been vaccinated quite a lot of their population, this was a news report today, zero deaths and 4 severe cases going to hospital in this group of patients who were vaccinated, which would have been so different if they had not been vaccinated. So now the question that a lot of people would ask is, what about these new variants? There are new variants in the UK, in Brazil, in South Africa, in Los Angeles, in Ohio, in Bristol, and what about these new variants? Again, we have written quite a bit on this. These were in the newspapers in Colombo, in the Daily Mirror and the Ceylon Today, and you can read this if you want more detail. But we know that RNA viruses will mutate. They mutate more than a different type of virus, a DNA virus, but of the RNA viruses, the SARS-CoV-2 virus mutates less because it has some aspect called a proofreading function. So we know it mutates, it will mutate. And the thing is that what is the effect of this mutation? Does it affect the spread, mild or severe disease, the diagnostic test, therapeutic agent, the treatment, and the vaccine? That is what is the importance of these different mutations. So we know that we picked up these mutations, the UK mutation initially in November, when the number of cases increased rapidly, and we went into lockdown following that. And these are the changes that I've illustrated in the spike protein and other proteins of the mutations that give rise to changes. And there are a number of changes in the UK variant, which has been illustrated here. The South African variant came around the same time, and there was a common mutation, the N501Y, but there were other mutations, and especially the E484K, which was an important mutation with regards to vaccine efficacy. So implications of the UK variant: increased numbers of cases. It just in the southeast of England, it became about greater than 60% of the cases in mid-December. And the important implications of this mutant, as at the present moment, it increases transmissibility. Viruses like to be transmitted from one to another, because that's how they survive. So it mutates to increase transmissibility. There was initially, they said it did not cause severe disease, but now we know that it can cause some degree of increased severity in the disease and more hospitalization. But the effect on vaccine has been minimal, and that has been a few studies have shown that it has only minimal effect on vaccine responses and vaccine effectiveness. However, in the South African variant, which is different to the one that is found in the UK, it has gone to several countries now. This mutation, E484K, does affect vaccine efficacy, and that is one thing that people are observing very carefully as to the vaccine efficacy. You know about the different studies that have come from South Africa, and we will talk about it in the question time. The important thing to remember, because the immune responses have been so good, even when it falls down, the immune response, if it reduces because of variants, still you have some amount of ceiling space for it to fall down, because there has not been a mutant as such that has prevented all vaccines working at the present moment. And that is what scientists are looking on very, very carefully with regards to the mutants. So what I've done in this quick 20 or 25 minutes was give you an update on the basic aspects of the immune system, the antibodies, T cells, B cells, and memory responses. You do want to get a memory response. One aspect is, can we allow people to get infected naturally and get immune? The problem with that is you're going to overwhelm the immune system. If you live in a country like the US or the UK, you would know the problems it has caused. If it is millions of cases, millions of deaths, and it can affect responses such as cancer care, etc. Then you have the immune changes. I told you about the different COVID vaccines and the new variant COVID vaccine. And the important take-home message is more than 100 million vaccines have been administered so far worldwide. Thank you.
Thank you, Professor Suranjit, for an excellent presentation, and it was very clear and very informative. we'll go ahead with your questions and hope Professor is ready to answer your questions. And just a reminder, please be sure to type your questions in the question box in your control panel. It looks like we have numerous questions. And to start with, there is a lot of concern in Sri Lanka regarding the side effects of the vaccines. It Professor touched on it, and we see many people who had vaccines have fever, severe body aches, and chills. Do we need to worry about these side effects, or will it get worse when they get the second dose of the vaccine? Can you elaborate on this?
Thank you, Dr. Mubrak. Very good question. Any medicine, any vaccine would have ill effects or side effects. We would want those to be mild side effects so that the risk benefit is very much in favor of the benefit part rather than any side effect component. So with these vaccines, you would get local tenderness, local pain, swelling, fever, some chills, some rigors, some got headaches, fatigue, etc. But the important thing is that on observations around the world, that those were classified as mild to moderate, and they recovered very, very quickly. Now, we wouldn't want to have more severe adverse effects like Guillain-Barré, or there was a report of some case of thrombocytopenia. But of the 100 million doses or 44 million doses in the US, there were 36 patients with thrombocytopenia, but there's a background level of reduced platelet counts or thrombocytopenia, as we say. So the response, the reactogenicity has varied across the world. I know I've got many people have discussed with me about the sort of responses different doctors had. So there is reactogenicity, and that is the fever, the muscle pain, etc. But that disappeared very rapidly. What we monitor very carefully is for any severe or serious adverse effects that ends up with the person being disabled for a long time, etc. And so far, the response overall is that these vaccines are not producing that. With regards to the Pfizer vaccine, the second dose had a few more sort of side effects because that was already primed, and it was the immune system was getting into action and moving forward with regards to the action.
Thank you. Another question: people who had already got COVID-19 infection and recovered, I think you touched on this. Do you still need to get the vaccine, or will they have any special adverse effects because they had already had COVID infection?
A very interesting question. So firstly, whether you had COVID or not, you're expected to get the vaccine. That's important because natural infection, I told you, get antibodies and T cells. However, natural infection, it may not be, there can be a waning of natural infection, and you would want to boost that with a vaccine. So you wouldn't test to see if the person has had an infection before. You won't do that. You will give the vaccine to the person. Now we know that if there is already the immune response with the natural infection, one dose alone may produce more responses than having more response because already they have an immune response. That is there are some publications that are coming on in that direction. So you would get the vaccine, and what I would advise those patients is paracetamol, antihistamines can be taken before. They do not affect the immune response. That is very important to remember. They do not reduce the immune response. They may reduce the reactogenicity that the person has, but it does not reduce the immune response. I would not recommend a person taking oral prednisolone before the vaccine unless they're already on it for some other condition. Say some patients may be on it for a skin condition or a joint condition, in which case you don't tell them to stop it, but you wouldn't, a person who is healthy, otherwise healthy, you wouldn't tell them to take prednisolone, but paracetamol, etc., to reduce the local effects. And even if you have had SARS-CoV-2 in the past, you would get it. It is because people are asking, when do you get it? I mean, you won't get it when you are positive, when you're having the virus, you're expected to wait at home and not go all over the place to get vaccine. So you wait till you recover and then you go and get the vaccine.
Another question attached, I think you already answered. Is it safe to get the vaccine without doing a PCR or antigen test? I think you don't
Yes,
recommend that.
absolutely. So you do not, I mean, imagine them, we are trying to vaccinate billions of people around the world and trying to do antibodies and PCR test. No, you don't do that. So you go ahead and vaccinate the person. And this vaccine is for, I mean, even if the person, because that's a common question people ask, what, I'm a person with rheumatoid arthritis, I'm receiving many immunosuppressive medication, I'm a patient with immune deficiency, I'm having I'm receiving immunoglobulins, my immune system is not working. Should I be given the vaccine? Yes, that's a recommendation that we would make, because you cannot get SARS-CoV-2, that's COVID, that infection, that's COVID, by getting the vaccine, meaning you can't get it from the vaccine. If you get the vaccine and before the immune response starts acting, you may meet somebody with SARS-CoV-2 and get the infection. That is a different thing. But you can't get the vaccine, and because of the vaccine you can't get COVID. That is exactly why when it comes to the live attenuated, which people are developing. I know there was certain reports of live attenuated nasal vaccines, which people are talking about, started trials in London. Now, that live attenuated, because when it is live attenuated, means live virus that has been changed, that when it goes to immune deficient patient, it can change back to the dangerous one. So we would not give a live attenuated, but the AstraZeneca, the Pfizer, the Moderna vaccine, the Gamaleya vaccine are not live attenuated. They would not, by getting the vaccine, you can't get SARS-CoV-2 infection or COVID.
Right, thank you. We have got a set of questions from Sri Lanka Foundation in US. Some interesting questions. Some are specific to US. The J&J vaccine, how strong and what are the risk factors by giving a one dose of
Yeah, so
dose?
very, very good question. I think we would love to give a one dose, and the Oxford AstraZeneca vaccine started as a one dose vaccine. I mean, initially the initial trials was a one dose, and then they changed it after that. And that was the reason why there were problems with the timing, the second person getting the second dose, and that is the reason a certain group of people got their second dose later than 4 weeks. So it started the first dose, and J&J, Johnson & Johnson, went with the first dose vaccine, and they found, showed you the responses, good response in the US. It was less in South African variant and less in Brazil, but good response in the US. And they are going for FDA approval on the single dose vaccine. Now, single dose is very much easier. Just imagine among the doctors who have received it in Sri Lanka, you had received one dose. Okay, that's great, right? So immune responses have to be monitored. That's important, because the next question will come. Okay, you got one vaccine, a single dose or 2 doses. When do you get the next? Do you have to get a next dose? I mean, that is definitely coming. And then, do we need a booster in the summer in the UK because of the variants? Can they have a combined vaccine? So those are questions that come in. But the J&J vaccine would be a big addition to the armamentarium of vaccination, and that is why the US is very keen on that, because that is it's a viral vector vaccine, same adenovirus 26, and that's the first adenovirus viral vector vaccine that will come into the US, while the UK and Sri Lanka has the chimpanzee adenovirus vaccine. So the important thing to remember is one dose is great, right? It's very much easier than giving 2 doses. We're trying to get people to get 2 doses. You can imagine the logistical issues in the UK. They were told to come in 4 weeks or 3 weeks, and then they were told, no, you can't come at that time, come now in 12 weeks. So there are logistical issues, right? Even in the US, you found that initially the vaccines were manufactured, but they were not going to the people because there was vaccines were going to the sites but not being given to the people. But now things have been developed extremely well, and they're developing well in the US. And yesterday I was listening to a talk from one of the sort of big vaccinologists there, and that is developing well. We have to remember, Mubarak, that Dr. Mubarak, that adult vaccination was not something that we were doing on a massive scale worldwide. We have a childhood vaccine. I mean, now Sri Lanka is wonderful when it comes to childhood vaccinations, right? I mean, they're leading the world. I mean, they're really great, and people take it. But we didn't have this process of adults, when they became pregnant, okay, but we didn't have this big rollout of adult vaccine. So even the US, even the UK has been learning on the job and learning and improving the technology, the techniques of getting the vaccine. Because just because you produce a vaccine in the lab doesn't mean the person is going to be protected. They have to go to the site in Africa, site in Asia, because just because you have everyone in the UK or US vaccinated and immune doesn't mean that everything is fine, because it depends on the weakest country, the least vaccinated country, because this is a globally connected world.
Yes, good. There's another question related to that. If there is, for some reason, for example, they say a shortage of vaccines in Los Angeles, or for some reason, for fear if the second dose was not given, what is the risk and how it can affect the immunity?
Yes, I think that has been both in Austin and Los Angeles. Yesterday, I knew that in Austin too, there has been a possible shortage. So now in the UK, the Pfizer vaccine, that's one of the vaccines given in the US, and Moderna has still not come into the UK, but the Pfizer vaccine is given at 12 weeks. People are saying, I mean, the clinicians have asked for it to be given at 6 weeks, but it's 12 weeks. So the Pfizer themselves say that it's better to give it before 6 weeks. So the important thing is each country will have to decide at which time they're giving the vaccine. Now in the UK, if it's delayed just beyond 3 weeks, they would not worry too much. But in the US, they have gone for giving it at the correct dose, correct time. And at one time they were thinking of giving half doses, but that has not come to any sort of fruition there, because of the Jnj vaccine may come in. So the important thing is, if there is a delay, go ahead and get the vaccine as soon as it's available.
Good. There's another question. After you complete your 2 doses of vaccination, how safe is to travel, and what is the timeline, and can we avoid the travel quarantine?
Okay, so
People
I
are
think
waiting to travel.
absolutely. I mean, travel has been really affected during this last 14 months. And the important thing to remember is that there are some provisos to remember. So you get the vaccine, you get an immune response, you get the second dose, you get a boosting of the immune response. But it takes at least the output or the outcomes have been measured 7 days after the second vaccine in the 2-dose vaccine. And then you give a value, the efficacy of those vaccine. We have to remember that the vaccine efficacy has been worked out initially against getting symptomatic disease, especially severe disease, moderate disease, and the person dying. Still, the data about carriage of the virus and transmission, the amount of data are limited. Oxford has tried to do that, but still that paper has just shown that PCR positivity has reduced, and there are some positive sort of direction from there with regards to that it can reduce transmission. So despite the person receiving the vaccine, both doses, first dose, second dose, you have to follow proper social distancing, wearing masks, etc. Travel will open in the appropriate times when countries realize the R number has reduced to a certain level, certain amount of the population has been vaccinated, and because we are always striving for that 60-70% sort of herd immunity. If transmission comes down, then herd immunity, the amount that has to be vaccinated to get this so-called herd immunity, the percentage will be about 60-70%. So once those are achieved by different countries and around the world, different countries are monitoring it carefully, public health doctors, then travel will start. But the important thing is, just because you get the vaccine doesn't mean tomorrow you get rid of the mask, tomorrow you will forget about social distancing, you will have all the big gatherings together, tomorrow you will forget about hand washing. I think that is there for some time to come. The vaccines, the main thing the vaccines are doing now, it's reducing severe disease, hospitalization, ITU care, deaths. That is the big problem. Uh, when you're looking at it from a Sri Lankan perspective, some people would turn around and say, yes, but we did, the amount of deaths we had in Sri Lanka was limited compared to the other parts of the world. So why should we get back? This is a global pandemic because people have to come to Sri Lanka. You cannot close the country completely for years on end. So people are coming, they'll be carrying the virus, etc. And that's why the expectation is to get immune to the virus. And the earlier you get immune, the better, because the virus is definitely going to mutate. But if you have a protected population, the expectation is that even if the virus mutates, the vaccines would be effective, or you give another booster, that you combine the variant vaccine together with the original vaccine and boost the immune response.
There is another question for Ranjit. While virus vaccine, is it better, especially bring resistant mutations? Viral vaccine.
Whether viral vaccine will bring up, I mean, if you just imagine you have a virus, what does the virus do? I mean, it's the normal you have the virus which is trying to spread from person to person, because the more it spread, it multiplies and spreads to another person. That's what the virus will do. It goes into a human, it goes into the cell, multiplies, gets out, and then it spreads to another person. So when you attack, so mutations occur naturally. HIV mutates far more, HIV virus mutates far more rapidly and widely when compared to SARS-CoV-2. Influenza virus mutates far more, right? So the virus will mutate. But as the immune response increases, what is the natural fight back, right? The virus will try to mutate to be able to avoid the immune response. So that is called immune pressure. You know, there is some pressure on immune system. The mutation that occurred in the South African variant, the Brazilian variant, occurred without there being much immune response because not many people had been vaccinated. But that will occur. But that is why scientists around the world will be monitoring, will be sequencing the viruses that are produced in different people, isolated from different people. The sequence means they will look at the different letters that are there, or what is it made, the amino acids of the genetic code of the virus, so that they can work out the amino acid changes, etc. They will looking at that. And the important aspect with the new vaccine constructs or vaccine methods, that's the mRNA and the viral vector, in months they were able to design the vaccine, while the live attenuated, etc., would take far more a longer period of time. So at the present moment, Pfizer, Moderna, and Oxford AstraZeneca are developing a vaccine against the variant. So that's why in August or September in the UK, we might be getting a booster dose of the variant plus the original. Now we have to take that. I mean, that has implications because already there are problems about getting sufficient vaccines to go around the world. We know what has happened to Australia, right? Australia put a lot of emphasis on a vaccine that failed, the CSL vaccine. Now they are finding it a bit difficult to get sufficient vaccine. They're starting the program, but they're quite late compared to a lot of countries. They have still not started their vaccination programs. There is a vaccine shortage. That is why most countries would not be able to manage with one vaccine alone. It is not, unless it's a very small country, it might find it difficult to manage with one vaccine alone.
Yeah, in addition to that, there is a question combined. Can we take a different vaccine as the second dose? For example, they say once you get AstraZeneca, can you get the vaccine?
Good question, and things have been changing. So trials have started on that, or Oxford has started a trial on combining the different vaccines because what happened was now you had the chimpanzee adenovirus vaccine and you have a response. The Gamaleya, the Russian authorities were in negotiation with Oxford to see whether they can give the Gamaleya vaccine as a second dose. And there are trials going. At the present moment, at present, it is if you get one single vaccine, you boost with the same vaccine to get the memory response. However, as it goes further, you may find that trials coming out and that the advice changing. So at the present moment, you are advised to get the same vaccine unless there's a massive vaccine shortage. Say if you take 6 months to get the second dose of that specific vaccine, they may have to revise, but that is again the public health bodies would produce guidance on that.
There's some a different form of question. They really like to know the real constituents of the vaccine. Does it contain any animal fat, fetal tissues, egg proteins, or anything else in this to call it a vegetation or it's a halal?
Okay, so very good and very important practical questions, extremely important practical. It does not contain any animal or human proteins. That's important to remember, right? There are additives, there are emulsifiers, there are stabilizers, and that one of the stabilizers was one that was thought of as causing the allergic reaction. People with egg allergy, people with nut allergy can get the vaccine. People with latex allergy can get the vaccine. People with penicillin allergy can get the vaccine. So for all religions, for all ethnicities, etc., there is no restriction in the vaccine that have been approved so far. There is absolutely no restriction because it does not contain any animal material in the vaccines.
There is so many questions about the age groups, regarding the age groups which the vaccine is recommended. So there is one question specifically asked, a 95-year-old gentleman with a mild hypertension, do you recommend the vaccine? That is a specific question. Apart from that, above 65 and with other comorbidities, is it risky? The multiple questions.
Yeah. So firstly about morbidity, comorbidity. If you're over 65 and have comorbidities like hypertension, heart disease, diabetes, obesity, etc., you have a higher chance of getting COVID and dying. I mean, that's the group you will somehow target and give the vaccine because that is the group that has a higher risk of dying of COVID. So the vaccine has definite benefit from in that group. With regards to 95, we know that many people, right, we see in clinic now are in their 90s in the UK, and we know the royal family were in the 90s. They've got received their vaccine. The head of the royal family in the UK, they have received their vaccine. So it is. I don't think there is a process for ageism here that because you're over this, so therefore we should not give you the vaccine. There may be some aspects with regards to that certain countries, if they might give one group of vaccines for this age group, another group of vaccines for another age group, but WHO has approved. Now, AstraZeneca vaccine was approved by WHO across the age groups up to 18 years. That's important to remember. Older than 18 years, across the age group. There was no limitation. Germany and France came with different sort of changes to their vaccine protocol. However, the UK, you would get, even if you're 90 years, you would get the vaccination. There is no restriction with regards to age. That is very important. Another important question that comes with that is vaccine mandate, right? That is to say, would doctors be told you can't work in a hospital unless you have got a vaccine? Would airline staff be said you can't work in the airline unless you've got a vaccine? Would there be a vaccine passport? That is, you can't enter Sri Lanka unless you have got a vaccine and show you have to show that you have got the vaccine. Because in hepatitis B, you can't work in hospital unless you have got immunity. Right now, we don't measure. So vaccine vaccine mandates may also are being discussed, but I think it is employers who might put the mandates initially, as opposed to countries put in the mandates. But when it comes to travel, that has to be taken, because those are the discussions that are going on at the present moment.
I think, thank you. There are many questions about this immunosuppression and vaccine. So many questions, one from USA, one from Sri Lanka, different parts about various immunological conditions and the safety of the vaccine.
Absolutely. So very, very good question. An immunologist that has been, I've been asked this question from the time the vaccines were showing promise. I mean, now what, because we have, I mean, at the Royal Free, we manage a very, very severely immune deficient patients. And should they get the vaccine? Yes, they should get the vaccine. Now, guys, we have to remember, guys, we are looking at antibodies. So far, we have focused a lot on antibodies, but there's a T cell response, there's a cellular response. Not can't produce a good antibody response. That is primary antibody response, because you might get a cellular response in this group of patients. Then with
Hello?
immune deficient is the patients who are not receiving that, but still they are recommended to go and get the vaccine. And in the UK, there would be a priority group to get the vaccine, as opposed to someone else who is low down in the who is completely healthy. And one other important thing in the US, smokers were prioritized to get the vaccine. And people would be wondering, why is it smokers should be prioritized to get the vaccine? It's because smokers did bad with coronavirus. They just did not do as well as, because when they got the COVID infection, they did bad. So the thing is that we're going to hospital, they're going to ITUs, etc. The idea is to try and prevent those patients. Patients are recommended to get the vaccine, and they are a priority group.
Thank you. I think there are a lot of myths about this vaccine more than the other vaccines in the world, because I think social media is sending news about this. And can the vaccine enter your cells and change your DNA?
Right. It's a good question. mRNA vaccines cannot do that. They go into the cell, they're unstable, they produce the protein, there's a component cell called ribosome, they produce the protein, the spike protein, and they just degenerate. They do not get integrated into the DNA. That's an important question, because there's a lot of myths that have been put in that that DNA that the mRNA goes and gets attached to the DNA of the human cell. No, it does not. There's no evidence that that happens.
Another interesting question: if you have less adverse reactions, means is the vaccine is less effective?
Oh no, I think that has been, again, people have been sending me the text message on WhatsApp, or I didn't get in many, so therefore why my friend got it. No, you can't. I mean, that is because there is reactogenicity and there is immunogenicity, right? So certain people can be, I mean, it's like pain. Certain people, you just push them a bit, they howl in pain. Certain people would not whinge. So you have, but it would be could be a similar effect, secondary effect. So just because you don't have any adverse effects of sort of fever, etc., doesn't mean that you're not going to make an immune response. No, that is not. You can't take that as a direct readout. So far, the studies don't show that.
Thank you. Another interesting question: do we need to monitor the platelet count after the vaccination?
Yeah, I think this was because of some news articles that was going around about 36 people in the UK, the US getting thrombocytopenia, but there's a background level of thrombocytopenia in people. I mean, in the general population, like Guillain-Barré, there's a background the background prevalence of or incidence of Guillain-Barré or thrombocytopenia. So nowhere do we in Europe or in the US, do we monitor platelet counts after getting the vaccination or getting full blood count? We do not do that. We do not measure antibodies to see whether they have responded. No, you don't do that. So far, we don't do that. We give you the vaccine, and the expectation is that they produce antibody response. But studies are going on in population level to see whether another vaccine may need a booster dose may be needed of the same construct or same vaccine, or whether they would need a booster dose of a combination of the same original version and one targeted against the variants. And those studies will come up, and there'll be data coming up quite soon.
Thank you. Another question on, is there any inhalation vaccines in the pipeline?
Yeah, so that would be great if you can get some sort of nasal vaccines, and there are about 4 I know that that the people are doing studies on, and that would be really wonderful if you can get a sort of a oral or a nasal. But the thing is that studies have to be done. Just because you see a paper article that it was tested on 30 people, it doesn't mean that tomorrow it will be rolled out. So parallel studies are going. We are using it intramuscularly at the moment, but other modes of introduction are being considered, and that would be great because, like the influenza, you have a where you have a nasal preparation. In the same way, if you can get a nasal preparation that is safe and effective, or as a booster, that is what is being targeted against, targeted as.
Thank you. It looks like we have covered most of the questions, and now it's time for us to wind up. Professor Suranjit Seneviratne, if there is anything else you would like to tell before we wind up, as your take-home message to the audience.
Yes, thank you, Dr. Mubarak. It is 100 million people, more than 100 million people have been vaccinated. Social distancing, wearing masks, hand washing, etc., is extremely important.
Tell him to.
We have controlled this.
My video is not on.
We have
He has to put my video.
We have controlled this with lockdowns and using social distancing, etc., and brought rates down, and that's great. But we have to get over this pandemic. The treatment, we want to prevent people getting to hospital, getting to ITUs, and dying of the condition. And vaccines appear to be doing that. So therefore, there's a push towards vaccinating the populations across the world. And one country vaccinating alone and being happy about it would not be the ultimate goal, because vaccine, there should be vaccine, as we said, democracy, because all populations should have access to the vaccine. Otherwise, you'll find that 2 countries will be fully vaccinated, but then people from other countries who are not vaccinated would go into that country and cause a problem. Or if there's a variant in the country that is not vaccinated, then again, there can be a problem because the original vaccine may not work.
Thank you. Thank you very much, Professor Suranjit, for this excellent presentation and clearing most of our doubts, the vaccination and the effects. And thank you for being with us. I just hand over mic to Dr. Hazare.
On behalf of the Independent Medical Practitioners Association of Sri Lanka, I would like to thank Professor Suranjit Seneviratne for having enlightened us on this very important topic of COVID vaccinations. And I think that by the number of questions that went on, we could have continued for a long time more. And Suranjit is a excellent presenter and also has knowledge on this vaccination program. Thank you, Suranjit, for the excellent presentation. Also, I'd like to thank our moderator, Dr. Mubarak, who had done an excellent job for this evening. And now, I do not like to take any more of your time. but also like to thank all the participants from all over the world who joined us in this webinar. On behalf of the Independent Medical Practitioners Association of Sri Lanka, let me wish you goodbye. Thank you.
Thank you. Thanks.